Assalamu alaikum. Today lecture is about temporary management of temporary pacemaker in the ICU. It is a short lecture regarding the nursing protocol in the ICU, monitoring of the pacemaker, and the fate of temporary pacemaker, either removal or shifting to permanent pacemaker. A quick revision about overview and fundamental of pacemaker. It includes indication of the pacemaker. It will have high-grade EV block, bradycardia arrhythmias, post-cardiac surgery, conduction abnormality, which require temporary support. The parameters should be involved like sensitivity threshold, capture threshold, pacing mode selection are critical for the patient safety. Monitoring should continuous ECG, hemodynamic assessment to ensure proper function of the pacemaker. Essential setup and insertion technique. Pre-insertion protocol, confirm clinical indication, prepares trial equipment, ensure resuscitation capability, and select optimal venous access, which can be femoral or subclavian vein, and the choice of the venous access depends on the operator and the patient clinical status. Sensitivity threshold. Understanding the significance of sensitivity threshold in the pacemaker is very important for effective cardiac monitoring and patient safety during the testing time. So what is the sensitivity threshold? It's the lowest electrical signal from the heart that the pacemaker can detect. Sensitivity threshold optimization. There is a clinical alert, very important, that improper sensitivity setting can cause missed pacing like oversensing or inappropriate pacing undersensing, and both of them are dangerous for critical ill patient. And we should have adjustment protocol, which can begin with a default setting, then fine-tuning based on the patient intrinsic cardiac signal amplitude so as to achieve reliable detection without any interference. We can monitor the rhythm during sensitivity. Patient safety, we should always put in our mind the safety and ensuring presence of external defibrillation ready and accessible, and the leads are securely connected. Also, we should for rhythm observation, we should continuously observe the patient native rhythm to identify any intrinsic activity before adjusting the pacemaker setting. Mood setting. Set the pacemaker to sensing mode to probably capture and respond to the patient cardiac activity. It's very important while checking the sensitivity to check the underlying rhythm of intrinsic rhythm of the heart. If the pacing is continuous and no native rhythm is visible, so we can reduce the output or switch to sensing mode like VVI to reveal the underlying rhythm of the patient. Again, sensing mode should be VVI for effective pacing if there is no detected intrinsic cardiac activity. Output threshold. Maintain output threshold more than twice the capture threshold to ensure pacing effectively. Sensitivity adjusted. Start with the lowest sensitivity, 10 millivolts. Put in our mind, the lowest millivolt is a higher sensitivity. How adjust the sensitivity? We will start with the lowest sensitivity, which is equal to higher millivolt, establish baseline capture, and ensure the pacemaker detect intrinsic activity. Then gradually increase the sensitivity, lowering the millivolt. So we will start with 10, then 5, 200, 2.5, 1.51, 0.5 millivolt. Observe for the inhibition of pacing by intrinsic QRS complex. So now, again, sensitivity threshold is equal to the lowest millivolt value where the pacemaker can sense and inhibiting pacing. Sensitivity testing, which involve gradually adjusting the sensitivity to determine the lowest level the pacemaker can sense. And it's very important to put in our mind patient safety and confirm the readiness of equipment and secure connection before the test beginning. The final testing should be 2 or more sensitive than threshold for final sensitivity equal to threshold divided by 2. For example, if the threshold of the sensitivity is 1 millivolt, the final setting should be 0.5 for the sensitivity. In this slide, we have three examples: proper sensitivity, lower sensitivity, and higher sensitivity. In the middle, this is proper sensitivity, and the pacemaker can sense the normal R wave, which is in millivolts. And so if sensing, the pacemaker will not start to pace. In the upper example, it is lower sensitivity with higher millivolt. The R wave is hidden from the pacemaker. The pacemaker can sense this is R wave, so the pacemaker started to pace regardless of the R wave, which can lead to overpacing from the heart, overpacing from the pacemaker, so it can lead to ventricular fibrillation or VTAC. In the lower example, the pacemaker have higher sensitivity and lower millivolt, so it can sense the T wave as a pacemaker, as a heart activity, so it start to not pace. So here the patient may go for a systole. And we should know that in patient who has unipolar temporary pacemaker, we should adjust the sensitivity more than 5, as the pacemaker can sense the phlegmatic contraction as electrical activity of the heart. The second part to be checked during the daily checking is capture threshold, and it's changeable in patients who are on pacemaker due to change in the electrolyte, maybe changing in the acidosis, hypoxia. All of these can be changed the threshold daily and should be checked daily. What's meant by capture threshold? It is the lowest pacemaker output that can cause the heart to contract. Capture is equal to pacing plus QRS complex. What is capture threshold? It is the lowest output causing consistent capture. How to test the capture threshold? We should set the pacemaker to VVI or VOO mode with a rate above the patient entrancing heart rate, typically around 80 beats per minute. We should put in our mind that the rate of the pacemaker should be more than the intrinsic heart rate to test the capture threshold. To test the capture threshold, we will start from output 10 milliampere, reducing gradually till we reach the minimum amount of energy needed to depolarize the myocardium. So as to ensure reliable pacing, apply safety margin, set the final output to 2 to 3 times the capture threshold. To summarize capture threshold management, so begin with high output, which is starting at 10 milliampere or higher to ensure consistent capture. Then we incrementally decrease or gradually decrease the output to 0.5 milliampere while we are monitoring ECG. Then identify the loss of capture, note the output with which the myocardial depolarization is failed. Then set final output, which is programming 2 to 3 times above threshold for the safety margin. Everything should be documented for the value to test the session and to track changes that might indicate maybe there is displacement or myocardial injury. Patient who has hypoxia, acidosis may has require more capture threshold. If they are corrected, the threshold can be decreased. Here there is spike not followed by QRS complex. That means there is no capture. Should be the clinical nursing care protocol. Continuous monitoring requirement. Hemodynamic parameter tracking is very important. Regular assessment for the insertion site and secure lead fixation and verification. Documentation standard, breathing mode and parameter, current output setting, recent threshold values, patient response to the pacing, and site condition assessment. And sudden bradycardia or hypotension can indicate capture failure, and that require immediate intervention. In addition to permanent pacemaker, if we assess if the underlying cause is reversible or persistence, we monitor the rhythm stability over 24 to 72 hours, involve cardiology and electrophysiology for this decision, delay permanent pacemaker insertion until the patient is hemodynamically stable no active infection is present. So that will maintain temporary pacing support during transition. And we should ensure sterile technique, imaging guiding during device placement. An important step in pacemaker caring is infection prevention and treatment of the complication. And infection prevention can be done through maintained sterile technique during the insertion. We should change the dressing site with every 24 hours using chlorhexidine or impregnated dressing. Also, displacement management. We secure the lead with dedicated devices, minimizing tension on cables, restrict the patient movement if necessary, and verifying position of ECG and imaging if capture changes. Arrhythmia vigilance is monitor ROT phenomena, also adjusting the sensitivity if there is oversensing happen. Also, anti-arrhythmic drugs can be used if there is arrhythmias occur. Systematic weaning and removal. Weaning protocol, first we should confirm the presence of stable intrinsic rhythm, verify the resolution of the underlying conduction issue, gradually reduce pacemaker output, and test the heart's ability to maintain the independent rhythm, monitor continuously through telemetry or bedside ECG. Removal technique, prepare dry field, remove the securing devices, apply gentle constant tractions to the leads, apply immediate pressure to prevent hematoma, continue post-removal monitoring for 24 hours. Simple case study from clinical experience. First case is complete EV plaque, 72 years old with hemodynamic instability. The patient received VVI pacing, temporary support for 48 hours, allowing intrinsic rhythm to recover and safe weaning. Regular threshold testing prevent capture failure during the critical period of stabilization. The second case is post-cardiac surgery. The patient developed transient EV node dysfunction requiring DDI pacing, strict protocol, prevent infection during 72 hours support period, and synchronized EV pacing optimized hemodynamic during the recovery phase. These cases highlight the importance of the adherence to the protocol, threshold evaluation, and documentation, team communication to prevent any adverse effects. This is references of this lecture. Thank you, and waiting for questions and comments in the comment down.